2 seconds. There we go. That should work. Great. Okay. So thanks for all of you who are joining the first book club of 2022. So I sent this around last week, but so for the past few months, we've been kind of summarizing chapters from the relational analytics book that Jody and Heba put out. And so we're on to chapter 4, which talks a lot about kind of choosing a research and evaluation design, how to craft one, and then giving a few examples. So we have a small group. I've put together a few slides summarizing a couple of projects that they looked at, but we can make this kind of informal because there are only a few of us. So we'll go through and feel free to stop me at any point if you have any questions or anything to add. Just kind of create kind of a back and forth discussion. So I'll briefly start with kind of a background to how they define research and evaluation design. And then I'll give kind of a brief summary. They put together about 5 projects, so I picked 3 of those, and then have also picked 2 from our 2018 grant that have since been published. And then we'll leave a little bit of time for some questions and discussion, hopefully, as we go through too. So to start, let me go on. So as I mentioned, the first couple of chapters kind of talk about the literature behind relational coordination, how RC drives outcomes, how organizations can strengthen their own relational coordination. So the book kind of outlines the next natural step is to ask questions about how relational coordination can relate to your or our own organization. So how strong is RC in our organization? How might the levels affect important outcomes? Things like that. Questions we've been asking, but kind of that's the next step. And so the book recommends that one way to improve RC is to develop a research and evaluation design, particularly around questions related to cause and effect. So this chapter kind of designates research design as primarily used in universities. They talk about think tanks, used to develop new knowledge, as compared to evaluation design, which is maybe more of a practitioner, a funding setting, looking at assessing if the desired outcomes are being achieved by an intervention. They kind of designate that for the sake of what we're going to be talking about. I'm just going to refer to it as research design moving forward. And so to kind of get into, I just want to dive in. So the book identifies 4 common elements of research design that can strengthen a study's validity. So I'll kind of go through what they say. If anybody has anything to add, please do. But they start with talking about assignment. Obviously, they give the example of an experimental research design. You randomly assign participants to receive an intervention or a treatment versus a control group. They also go into, if you lack the ability for a random assignment, you might instead consider a quasi-experimental study or simply measure natural variations in relational coordination between groups. I think that's kind of one that we're most familiar with, but that's another option. The second element talks about creating comparison groups. So how comparable are the groups that you're studying? So while randomization is kind of the gold standard, looking at how to maybe include internal or external selection to maximize that comparability between the treatment and control group. I'll give an example of one that they talk about that uses a cool form of internal selection, but just kind of wanted to give a brief. And so the third, when you're designing your measurement, you kind of want to think about how often or when or how often you want to test groups and collect data. So are you doing a pre-test, post-test? Are you testing 3 different times, multiple times, things like that, to determine a baseline score and indicate a trend, all things to be considered. Obviously, measurement can be extremely time consuming. It requires a certain number of staff and people to help roll out the survey. So obviously this takes a lot of consideration. And then last, they identify treatment and intervention, considering how it's being assessed. Can it be replicated? In many studies, both experimental and quasi-experimental, the chapter makes sure to, when you're rolling out interventions, they need to be tested, retested often before being widely adopted and implemented. So these are 4 areas that the chapter outlines as strengths, helping validity. Obviously, this is also for research design, so it's like research projects, and so they might vary across what the focus is, what the bandwidth is, things like that. So that was a very quick run through. Does anybody have anything to add at this moment? We'll kind of dive into the studies next, but I don't know if anything has come to mind. Okay, so the first one that I wanted to talk about from the chapter is this study that examined the impact of system management practices on relational coordination and desired performance outcomes. And so this was actually based in Pakistan. It's a great example of relational coordination within a large multi-site organization. So they studied the State Bank of Pakistan, which has over, I think, 1,300, is what I said, branches. So this was just, I think, was key given the size. And also they sampled through kind of a two-step stratified random approach. So they first selected 3 regions to study and then randomly selected about, I think, 45% of staff from those branches to survey. And so they were mailed the RC survey and then also questions assessing management practices. And so that data, along with branch level performance outcomes, were collected over the branch level performance outcomes were collected over an 8-month post survey distribution. So the survey was distributed and then outcomes were collected to kind of to measure how these may be impacted by relational coordination. So results found that RC acted as like a partial mediator between high performance work systems and desired performance outcomes. So they interpreted this as high performance work systems impacted the performance outcomes through their impact on relational coordination. So yeah, I'm trying to think of how better to describe that. So they were looking at things through HR and others that there was kind of it was a mediator effect. I kind of picked this one given the size. It was also how they were able to randomize it through groups and who was sampled, I think, was important. That's something that you can't always do. So that was just a first one. Let's see. A second, this one looks as an example of a rolling intervention. So this was the one that I mentioned that used internal controls. So in this case, the internal controls were those that were waiting to receive the intervention. And so there was the intervention group and then those that were waiting. And so this study was set at a large community teaching hospital in Canada. And researchers were implementing a new platform that was designed to enhance interprofessional communication and coordination. And this was throughout internal medicine wards. So this platform included the addition of, I think it was an interprofessional care planner and a messaging system. And so in this instance, RC collected, the survey was collected at 3 different points. So that's kind of what I was talking about when you want to measure. So the first was a baseline, and then for both the controls and the intervention group. And then the second was after launching that intervention with the first group, but that would have still been a pre-test point for the second group. And then the last was after that, after everybody had launched, and that acted as a post-test data point for Group A. And the survey was accompanied by semi-structured interviews, and that gave a little bit more depth to the survey findings, obviously. So the findings, the intervention greatly improved RC in Group A. This was despite no change in face-to-face communication during that time, but there was no change to RC levels for Group B. This may suggest that the length of time between pre and post intervention assessments is important. That timing seems like a crucial bit. And this is kind of what they concluded. I don't know what others have thoughts about this, that they received the same, obviously the same intervention across all other communication, or, face-to-face communication, things like that. All the levels were the same. It was just RC in this between the 2 groups did not improve. I don't know. Obviously, I know people don't have access to the book, so haven't been able to read. But I'm curious what people think about that timing piece. Heather also, I think, had a chat about that. If anybody has, why would there be variation in that, maybe?
I mean, go ahead.
Variation in what was it?
So Group A received the intervention first, and so Group B, technically acting as controls, they did not. And so Group A, they were tested pre-test, and then immediately after the intervention was launched, and then post-test. And Group B had 2 pre-test measures, and then an immediately after intervention test. And so RC improved with the intervention for Group A, but did not for Group B, despite the intervention being the same in all ways but the timeline. Does that make sense? I don't know that I summarized that as well.
Oh, that's interesting. Yeah, did it? Okay, this is 2019, so it's pre-COVID, so that wasn't impacting it, which I feel like that's going to throw a wrench in everything. But yeah, that's interesting. And I'm curious too, did they say with Group A, so they did pre and then immediately post and then a later post?
Yep. So what I'm pulling this up from the book now, so I want to make sure I get this right.
And I do have the book. I just haven't looked at it in this much detail. It's helpful that you're going through it.
So when I read, I don't know that it says in the book, but I pulled up just as a publication, and it was they called it a post test, but yeah. Let me see, Christine, I can pull it up. But they yes, what you're saying, Rachel, is correct. So the second would be immediately post intervention for Group A. Let me see.
And Group B had 2 pre's and a post.
Mm-hmm.
That's interesting. Did it change at all between the 2 pre's? I'm probably asking questions that I should just go read the article for, but
yeah. Right.
So the thing I took away from this, because this is actually, I've reread this, I don't know how many times now, but essentially what they were saying is like, the tool itself was sort of helpful, but didn't make a huge impact on relational coordination pre-post, because it sort of seemed like maybe they, by just even coming together to start determining there was a need for this electronic tool, improve relational coordination among teams. Mm-hmm. And so I guess, the question I have, like with our work with the query group is if let's say Heidi and Bree are working really hard to get everyone to understand they're part of a team. And so everyone's like, oh yeah, no, there are roles that are involved with us and they're part of this team. And then we go out and quantitatively survey them. Just that pre-work is going to mess with our baseline potentially. And so the attribution, so all of a sudden they might have some pretty decent relational coordination, even as at quote unquote baseline, though they had done some work beforehand to establish that. And so then we will do, whatever interventions we choose to do, and we'll come back and maybe not see an impact on the quantitative assessment of relational coordination because it was the very pre-work that actually was so impactful. Because if you're starting at 0 and you see and you don't even know someone's part of your team, and then you're told they are part of your team, you should have good relationships and communication, you're going to go, yeah, I should. And that's going to move them maybe to a 2 or 3. And so then when you do the intervention, I don't know. I mean, Erin, you seem like you have something to say.
Yeah, no, I think that's really interesting. And I think we sort of experienced that a little bit, or we've seen that a little bit at our site where the act of defining what is the focal work process and how are you framing these questions is a team, at least for us, became a team building activity to be able to the process of learning enough about RC to be able to actually ask a useful question. For a subset of those who took the actual, and that's, I think, where I haven't read this particular study, but I would be curious if those who defined it, how many more people took the survey? Because I think that's how we felt okay about it, is that it was a small subset of people who were involved in that definition phase. And then a way larger group took the actual survey. And so we were like, we're just going to sort of let this go. But I do think that in a lot of situations, it is even just the act of writing the grant to get the money to do this RC study and then to frame the questions changes the team dynamics, hopefully in a good way. But yeah.
Absolutely.
Thank you. Thank you, everyone.
Yeah, when we were just writing something for the relation for an abstract, the RC survey is meant to be like a broad diagnosis, right? So it's like, so I like the way you say that. If you, as long as you make it broad enough, you should get an actual evaluation of the state. That doesn't answer this issue, which was what's the timing, right? Between how long does the intervention need to be in place? What's the I think the dose is the word I use for it. What's the dose that needs to be done to truly have an impact? I've never seen any data on dosage of relationship interventions.
Mm-hmm. But it would stand to reason that you would need at least a little while. Because it's not like a training evaluation where you're immediately afterwards, it's common practice to say, how did you like this? How did this go for you? Or did your knowledge change? But relationships take a lot more time than that, or at least that's usually how I think of them. Like, you could change somebody's optimism about things being about to get better, but I don't know you could actually change the relationship.
How would you study dose? Do you have to then do it like every month? Like, do you feel, I don't know, I'm asking the group, so let's say so you're starting huddles. I assume you're going to say, like, if you're doing a structured huddle where, you do sort of relational interventions, like everyone introduces themselves and states the purpose and follows sort of a structured relational checklist, shall we say. How many huddles do you have to do to say this is now standard?
That is a really good question.
Yeah, I think it depends too on who is initiating those huddles too, right? Like, we have for the quadruple aim query project, Heidi and Bree are working so closely with these teams, and you may be working with them and they might be doing the huddles as part of oh, these people want me to do it. But then when you're gone, they might just stop. So it might not even be practice, even if they're doing them consistently, if they're doing them just because it's something they feel like they have to check off.
I mean, what's the flavor? Everyone says it's the flavor of the month. If we hold on long enough, it'll go away.
Yeah, and it seems like a lot. What is common practice and what we've done is to do annual ones, which seems like that's enough time for things to have changed. But that's a really long time in the course of a grant or a project or something like that. That would be something that would be really interesting to get a sense of, if you were to do it 3 months later, is that enough time to move the RC in a substantial way, and to do some of these dimensions change faster than others?
It's interesting because in Christine Jones's project, she's doing care coordination with home health. We're proposing we'll do a baseline and then what, end of year 4 or year 1 or what? I can't remember now.
I thought my understanding isn't it the end of the grant or near the end of the grant?
I don't think so. I think we were going to do it pre-implementation and then post. So once they're kind of moving into their sustainment phase.
When is the sustainment phase though, Christine, especially with how delayed everything is becoming?
The sustainment phase is about a year after we start implementation, which, as we all know, is kind of, how do you count that in our first site? Who knows? But I think we've just kind of defined the endpoint is June, July. So we'll do one now and then one in June, July. So that'll be 6 months apart. Okay. It's just to give everyone else context, it's just been a constantly moving, staffing shortages, COVID related challenge. And so we get implementing and then someone's out on leave. We get implementing and then there's a staffing issue. So it can be hard to do this in a pragmatic way.
But I'm wondering if we should actually have them, if we should do the survey again a year out. So do the, the 1 year sustainment and then the phase 2 sustainment.
You could, but you're assuming it'll be the same staff and they'll still be working there.
But if it's
a huge assumption.
If we're doing an intervention that is meant to change the structure, the organizational structures, and not the individuals, then it should stay, no matter who's in the role.
Theoretically, but people might broadly, like, differently define how they how they answer questions, right? They might all have different levels of how they calibrate their responses on the RC survey.
Yeah, it seems like if it was a big team with a lot of people involved, that changing staff probably wouldn't matter so much. It would come out in the wash, but we're talking about much smaller groups that would actually be completing the survey, right?
I mean, it's worth keeping in the hopper, but I'm just, from what we've seen so far with that site, it's going to be fraught.
I'm curious.
Well,
I'm sort of excited by this now.
Well, I think I'll cover it because the next study kind of goes into a little bit of like, how do you design these programs like with sustainment in mind? They were looking at, I'll just pull it up now because it's part of, obviously.
Can I just interrupt for 2 seconds? So Erin, you did this though, longitudinally. You must have had significant staff turnover.
Yes, we had a lot of staff turnover. So, because we're an academic medical center, so we had residents and fellows completing the RC survey along with attendings who were probably the most stable group, but it's also like an ICU and a step down floor, and so there's constant RN turnover as well. And the way that we were thinking about it is that it was the culture of the teams, and so because the changes that we were making were ideally going to be self-reinforcing, and that we would be assessing it serially would help us understand if the culture of the team had changed over time, which it did. And so we did have, and we ran things both because we had this same question. We did the analysis both with just people who had been there the whole time. And so like and we did this each year, I think. I would have to go back and look and see, but like definitely from the first baseline to follow up. And then I think baseline to like for each of the times, because we did 4 or 5 years, and the results were very similar if you had everybody who responded at each time point, regardless of if they had done it in previous years, or if you limited it just to the people who had filled it out every single year. The results were pretty close. Like they were not statistically significantly different, which helped sort of support our thinking that like, okay, what we've done is helped this team improve how they're communicating with each other and how they're relating to each other, which is fostering this better relational coordination in terms of how they operate. Like this has become the norm. Our last one was literally in February of 2020, right before COVID. And so I would love to go back and do it again, but right now there is no bandwidth where we are tapped. So
thank you, Erin. I appreciate it. Sorry, Bridget.
No. I mean, this one kind of gets at a little bit of what we're talking about, so I want to discuss more. This it's a little bit different in nature in terms of the population that they studied. Many of the others and a lot of the ones we're talking about are used like amongst professionals working in the same organization. And this one actually looked across multiple organizations. They're working in the same city and to serve the same population, but this specifically looked at kind of many different organizations looking to address the social, sorry, that's my radiator if you hear clanging in the background, no one's breaking in. They were looking at organizations that were addressing social, physical, and psychological needs of at-risk and gang-involved individuals. So this study looked at 4 different cities, all in the same state. But so 2 of the cities were receiving support for their RC interventions, while the other 2 remained as controls. And so here's kind of what I find to be interesting is City A, I mean, both cities underwent kind of some organizational change mechanisms and interventions, but City A included a boundary spanning role that would follow up on the implementation of a lot of their protocols. And City B had, I think they developed like a steering committee, but no one served as a boundary spanning role. And so in this study, the survey was administered to all 4 cities at baseline at 6 months into the intervention, 18 months, which was also the end of the intervention and end of all the RC interventions, and then at 1 year post-intervention. And so I think I mentioned a little bit on screen, but given what we're talking about, do people have guesses as to what the results showed, particularly between City A and City B, that what the boundary spanning role may have done? Because both City A and City B did show a statistically significant increase in RC scores throughout the intervention, but that 1 year post-intervention was different. Actually, it was the last two data points were different for City B, and so the results. So there was no change in RC for control sites, and then significant increase for A and B but for City B returned to baseline actually during the last two assessment points, seemingly due to the lack of a boundary spanning role. And so this kind of highlights the need for these structural interventions that have a clear focus. If you can have them, structural interventions with a clear focus on like these ideal outcomes. That role actually made a statistically significant difference for City A. Obviously, this is in the most ideal circumstance, and we can make this work. But I thought just this highlighted that sustainment bit in a pretty interesting way. I don't know if anybody has any thoughts to this, given what we've been talking about.
I mean, it's funny. I've read a bunch about how these boundary spanning rules are so crucial. But then again, they are an absolute crux for they're a crutch for many. Many drop out. They don't have to do it. The boundary spanner's doing it. And then the minute that particular boundary spanner goes, if they're gone, right? So it's like, I think we know it works. How do you replicate it? How do you sustain it if that person goes? I like what Erin was saying around, it's actually, if you focus on changing the culture, that potentially is sustainable. But I mean, that's a long-term investment compared to, we can get pretty easy data out of the win of putting in a new care coordinator. And everyone gets happy and everyone says, look at us, and we get a nice publication and aren't we amazing? And then we can't keep those people on staff and dollars go away. And not to bring up our transitions nurse program, but prime example, right? Of as soon as money went away, program went away, boundary spanner went away.
Any other thoughts? If not, I can move on to the next two that we'll just kind of briefly cover. Were part of the first iteration of the RC and VA grant. So kind of I'll briefly delve into them, but there's more reading on this that I can send or that I can link to from our website. So this first team looked at levels of RC amongst groups that were implementing a whole health initiative. I think it says at 18 sites. This is part of a large intervention initiative. And so they talk about how the initiative requires coordination amongst clinical, administrative, leadership stakeholders. And so we're wanting to look at how levels of RC might result in the implementation process, and then in what roles might RC be higher? How might this factor into the whole health model? And so this was also the first known use of the RC survey to assess cultural transformation and implementation specifically, I believe. So they found, I mentioned this here, but they, our survey used the RC survey kind of with many different teams. They have the whole health core team, kind of education and clinical champions, employee health leaders, but then also executive leaders and different ambulatory care service staff. And so they found that kind of across sites, participants experienced higher RC in those roles that are dedicated to whole health implementation. So those would be some of the core team members, those would be the clinical champions, integrative health leaders, people like that, and then lower RC around executive and ambulatory care leaders, often the roles that would have predated the whole health model. And so And then they also found face validity with individual sites. So the individual site corresponded to kind of qualitative level site data. And so I think my understanding, Heather, and step in, but they're wanting to kind of facilitate future, guide future whole health interventions around this, and maybe more grant proposals. Do you know exactly around this right now, what they're thinking? I know you might be in touch.
Yeah, my understanding is that this was just a layer of all of these multi-site implementation works that we're trying to say, like, we need to study this as well to understand what is it that helped this be implemented. Unfortunately, Rendy, who Erin knows as well, she's working on her dissertation, so she's never gotten around to publishing this, but it was shared with the appropriate VA offices. I mean, it sort of was a no duh. I think that's what they sort of took away from it. And actually, an evaluation that the Query Rapid Response Group just did with VISN 8 sort of showed the same things. I mean, the idea that if people were dedicated to the whole health, things were just fantastic, and people who it was sort of assigned as a second position or third position or fourth position unpaid, it fell apart. Mm-hmm. Which is not surprising, but something we do all the time. So what do we do with that knowledge?
Right.
Does that mean, so I guess this is a question to the group. If we know this, if we know that someone is dedicated fully to the program and others are just, it's, going to be another addition to their workload, who do we prioritize working with? Because instinctively, we would probably go and work with the group that was easiest to get, right? The people who we've hired to be dedicated to our program. Are those the ones we should be working with?
I wonder too, like how much of that is a bandwidth and like how many other hats people wear. Like I don't know about this program, but I assume that the whole health, like the champions probably had more of their time protected for this. And so it's not necessarily that you don't want to work with the other people, it's that the other people just have so many other things on their plates that they're perhaps less available or maybe not co-located.
But should we, I guess that makes it hard, but isn't that the right place to go?
To go to the folks that are harder to get to?
Yeah, to work on relational coordination with the folks that are hardest to get to. And I guess it has to be through the person that you're dedicating the program to.
I think you have to make a strong case for the value proposition for them. If they're not getting time protected, they're not getting resources allocated to them, it's going to be harder to get them in some ways to buy in, unless you're like, this will save you X, Y, and Z from this role that you're already doing. Because otherwise they'll be like, well, there's somebody who's paid to do this. Why are you trying to work with me?
Yeah. So what was neat about the study, I will say, is they were able to get to 18 sites and do this work. And they had a pretty good response rate. And then because they had a lot of the VA data, quality outcome data, they had proposed that they were going to do some longitudinal outcome work as well. And that's actually, I think you might did you touch on that in one of the other studies? Oh, maybe not. The first one that they presented in the chapter is the Dr. In. Jody did this back in 2008, Dr. Cattell. And yeah, they did a sort of a simple relational coordination piece and then used tons and tons of the, quality and outcome metrics the organization had, which is something that, relational coordination is not an end in itself, right? Anyway.
No, thank you. I'll go on to the last one and then we can I'm going to dedicate a little more time to discussion. I have a few questions for everyone. So This project also used the RC survey to study communication and collaboration. This was amongst staff involved for pain care for veterans. And so kind of trying to answer the question, how does the quality of relational coordination maybe impact veterans engagement behaviors and kind of pain management teams, or at least pain management teams that would be predictive of veteran engagement and behaviors. And so they looked at, I think it was across, 8 VAs, looking at primary care staff, pain management staff, compensation and pension, so C&P is how they refer to them, and then administrative leadership and staff. And so, and these are kind of with semi-structured interviews, and then also with the relational coordination survey sent through REDCap. And so kind of all the work groups that were surveyed, the C&P, the compensation and pension team was actually kind of rated, this is what we've been saying, like rated low around coordination with different work groups. They seem to have the least amount of communication with other teams, and did not report to be very, if at all, involved in getting veterans care for kind of pain management and painful conditions. So that would be through primary care or pain management. And so kind of, again, highlights maybe an underused opportunity that does impact veterans' access to care, but again, kind of calling into question how much can be done, what is the nature of that team, that is there an intervention that can help? Is that kind of the nature of how it's organized? This team actually, the study group actually submitted an application to use the RC survey in 2023. So we'll be excited to help them continue their work. But I think, again, looking at it from with a different group, but similar results. And obviously, again, some not as, but just wanted to further highlight that. Any thoughts before? I have a few questions, but wanted to give people time to reflect on this one too.
I mean, what I thought I was sort of envious of when they did the study is how, people just work in like the people who are doing compensation and what is C&P again? Compensation and pension. Like that's in their job title, right? So like it's easy to find them, even though they have no clue. Maybe they're part of a team. It's easy to find them. But we tend to be working in these situations where they're like, we have no clue if someone has a title, and they often have this, we can't find them. This made me jealous. It was easier to find people who were actually supposed to be, in that role. So maybe for our next studies, we find a really well delineated role that's like in their title. They have one boss, and all of them work for that person. Sounds heavenly. And it begs, is that easier?
I think you're right. Like, especially in the acute VA setting, it just seems like you go to one VA and the person with this job title does this scope of work. You go to another one and it's way over here. It's kind of fascinating and frustrating, but fascinating.
I mean, there's a comparison. I mean, like there's ICU nurses and hospitalists, and like there are some groups that are, but is there a theory? Is there a theme here, right? The coordination or relational coordination is hardest with groups who really are not well bounded.
Yeah. So I have a question on this one. So this is looking like, so across these 8 VA sites, all of them, the C&P teams at each one had the least strong RC with the other work groups. Is that accurate?
Mm-hmm.
That's interesting. And who is it? I guess maybe one question would be that they might very well be asking as well, is sort of what role do they play? What role should they be playing with these other work groups? And I as a non-VA person, I don't know how a lot of these things work. So
No, I think your point's really good, because I actually think that the CMP folks work for like the Veteran Benefit Association.
Okay.
The VBA is then there's the Veterans Health Administration, and then there's like the cemetery group, right? So like they're within the VA, but they're not clinical. But I think that this group is saying, but you need to be clinical. You need to know that if a patient is having pain stuff, that it's more than just making sure they get their compensation. You now need to refer them to pain teams to help them take care of their pain. Which is sort of interesting. If the philosophy of an organization, if the culture of an organization is that, and there was, when I was oriented to the VA, it was like, I need you to know everything about, or at least know where to go for all of these groups, so that if a veteran or their family comes to you, you can say, I don't know, but I know where to give the answer. I'll be right back to you. And I think this group is flipping it on its head, saying if someone comes in because they're saying they have chronic pain and they're seeking compensation and a pension for it, you need to then make sure that they're receiving at least in contact with the appropriate clinical teams to receive care, not just compensation and a pension for it.
Yeah, which makes a lot of sense. But I can see where, if that's not how things have been done in the past, that the CMP people might be like, what? You want us to?
Absolutely.
But it's one of those opportunities, right? I mean, sort of cool.
Yeah, but you could also, like, it would make sense to me from sort of the veteran perspective that, like, if I'm coming to you about compensation and you have other services within this system that are meant to help me with this, that you would be like, this would be a group that would let you know or refer you or something like that. Like, I think outside of the VA, that's one of the things that we see a lot, is that people are like, so one part of your system does this thing that would be helpful to me, and the other part of the system isn't actually tracking that I'm not doing this and that it would be useful. So
yeah.
Well, and I think here, this is kind of two general questions kind of about, given what we've been talking about, but maybe we've answered a little bit of it, but I think I actually wanted to start with the second one. So these like topics of areas of research within the VA that you could think could benefit from this type of work, and where these efforts could go. And so obviously we've been talking a little bit about feasibility of design, and where are the areas. It sounds like some areas are pretty well covered, or at least we expect to see a certain type of result, but can everybody think of are there other topics that would benefit that haven't really been touched by this?
Hey, Bridget, do you mind if I ask a question before we dive into these?
No, not at all.
Yeah, so going over those studies that you were just talking about, one of the things that I've been having a hard time wrapping my head around is, do you or anyone have a sense of these research teams, their relationships with the folks who are doing the intervention itself? Like, are they internal folks that are doing the relational coordination work, or are they like our projects where we're kind of coming in from outside and we're part of the implementation and we're doing it, or are they like completely separate from all that and doing it? Or do they even talk about that in the articles?
That's interesting. At least the ones that are not VA, they don't really talk about it, which I think is interesting. Heather, do you know offhand? Are you familiar with?
My impression is they're doctoral students.
Yeah, it's mine too.
And it didn't indicate. Often you'll see like that someone like Tony Sukman, who does a lot of consulting around relational coordination. He'll be a co-author if he was part of the intervention. So the folks from oh my God, help me, Montana, Billings, when she talked to us last month, that was a supported intervention, where these really seem like a bit like us.
Yeah, that's one of the things I've been really curious about in this work, in evaluating or researching relational coordination, like how it can play out differently depending on what the roles of the people who are doing the Heather, that term you kind of coined, the relational facilitation piece, and like actually facilitating this side of the work, I feel like probably have a really big influence on how it all plays out and the data they're able to get. Yeah, thanks. Yeah, that's something I was wondering about, and it sounds like, Heather, you're saying it's probably a lot of doctoral students, and then also people like us, and all over the map.
I also wonder, like within what concentrations that also, I mean, I would imagine like healthcare, and that's maybe a problem's the wrong word, but it makes it really difficult. I wonder, like for the example of with the bank, like in what areas does it almost not matter as much, and in what areas is that a huge, just a barrier that you have to work with? I don't know, because I'm so wrapped up in RC related to healthcare, and that almost sometimes feels like a different beast in and of itself too, with the barriers that we're often up against. I don't know, because as you're talking, Rachel, I'm thinking about that. It's like, well, would the banking team have the same issue, or would I don't know.
I mean, I think in a perfect world, the way that this is done is there's a diagnostic piece, right? And then the intervention piece is really owned by those, to be honest, who manage and review and bonus the people, right? We've run across this as implementation scientists. These people don't report to us. And so I think we're better than the consultancies who show up, tell you what to do, and then pull out, right? And at least we are embedded researchers. So I think that there's some benefit to that. I mean, Erin, in your world, you're an embedded researcher at UW.
Yeah, sort of yes and no. Like I think it would depend a little bit on who you ask. Like there's a bunch of people who do know me and would say, yes, if I was going to have a question about this, or if we were going to work on something, Erin is who we would work with on this. But then they're like, especially with some of the turnover that's happened since COVID, there are a bunch of people who have no idea who I am. So I think it sort of depends a little bit on sort of how you're doing things. But I think I'm perceived as more internal than like an external consulting company. By being within the UW and having a track record of collaborating with these groups. So. I thought, Bridget, what you said about sort of the similarities and differences of the banks, as I was watching all of the many flights get canceled all over the place over the holidays, I was remembering that Jody had originally developed this working with the airlines and particularly Southwest, which I think has had some rough times. My brother-in-law is a pilot for them. It's an interesting holiday season, but it was, yeah. So I think it depends on sort of like the characteristics of the work that's happening, but I think in a lot of cases it is super applicable outside of healthcare too.
I mean, I've been impressed by reading how this has moved into, this is, the education field, right? It feels really intuitive for it to be in the education field. And then just one of the studies that you presented around gang violence, right? In the justice field. I mean, it is sort of, so I feel like this a lot, and this is why probably I am an implementation scientist, which is there's millions of evidence-based practices out there that we know work. We just don't know how to make them work. And we don't know how to make them work when there's a worldwide crisis, or when there's turnover, or even when there's times are good. Like, I think for me, that's, my next 20 years is like, how do we at least get something to stick? Because we know it should. Even checklists, right? Like right now, people have abandoned checklists. They do them half-assed. They do them, and you just go, but we know it works. What is it about human nature that we all regress to the mean? Anyway, that's a depressing topic. Let's end on a good note.
Do people have any other thoughts about I said within the VA, but it could kind of be anywhere, where this kind of work, where these efforts could go. Where's the, what's next kind of? I mean, I think, we talk a lot about it within a care coordination focus, but are there others that, it's kind of what we've been saying, what, often those that are the hardest to get or hardest to get through could be the most beneficial, but I don't know if there are any that immediately come to mind.
I will say one thing that Jody mentioned in a meeting that Bridget and I had with her last week is that they're going to test out pulse surveys. So get the pulse of relational coordination. And that was something I saw at the Denver conference. I think it was like the Danish group who had a cartoon that they would put at a construction site and people could just be like, yeah, here's our relational coordination. And part of me wonder, I mean, maybe I'm saying this out loud, but maybe Christine, we can try this within our projects, right? Like, why couldn't we do a pulse survey and be like, how are things going? And if things are stable over 3, then what? Or stable, because I think to go back to the concept of dose and to go back to the, like, is it at a year? Is it at 6 months? Like, I love the idea of a quick pulse survey, but I'm a big fan of, like, when you walk into a bathroom in an airport, right? It's like, how clean is it? Unhappy face, neutral, or smiley face. Like, that's good data. Why don't we do that more often? But
yeah, and I don't know if you have had, I think after the last session, I've been having some conversations with Jody and Heba about asking questions of patients and families. Mm-hmm. And I was talking to them a little bit about the idea of these pulse surveys, and it sounds like it's still an idea that people are interested in, but that could be a really interesting thing to do within the VA. If you like to try that out and see how well that works, because I do think that, like, part of the reason that we've gone with annual surveys is just because if you're going to do the 7 questions per work group, like, this thing becomes really arduous and people aren't going to do it more than about, at least for us, more than about once a year. And so, but they would answer sort of like a 7-question thing via text or via RedCap or whatever, that a lot more frequently.
I don't know, Rachel, not to give you like more ideas of things you need to think about for the query calls, but I feel like you could almost do this, like, everyone's on a query check-in call. Like, how are we feeling? Everyone's on an ICOR call. How are we feeling? Like.
I don't know if I want to see that data.
I know, right? Don't invite me to the call. But no, I mean, it could be interesting to, like, do that on some of these, I don't know, even smaller subgroup team calls within our query itself. It could be interesting.
Rachel, I will work on that with you if you want.
Yeah, I mean, that definitely could be interesting to think about. How do we look at our own team in this broader picture? That's something I have been toying with, is a little different than that, but like the relational coordination of the researchers with the groups that they're working with, and how does that interface with how the projects play out?
Yeah,
that's such a good layer.
Yeah.
And it's a good layer to work on because we can't touch the clinical people right now, right? Once maybe our next COVID wave comes down, like.
Yeah. Well, and I think it could be really interesting. I think Jody's concern and Heba's concern when I was talking to them was sort of how do you frame it for people so that you're kind of getting at the same thing, that when you ask them all of these sort of broken down questions. But I feel like people could answer these questions about sort of like a gestalt version of their work with their team, as long as they're clear who you're asking about. I don't know, it would be interesting to look at.
Super interesting. Because, I mean, think about it. If you're a care coordinator and you have it, hopefully it will level out, right? You're having a bad week with someone, or a role, but then a good week the next week, you could start to see and understand these fluctuations. I mean, Bridget is a future psychologist and therapist. Find out for us if we're supposed to, like, when you check in on therapy all the time, is it something that you're supposed to, like?
You're supposed to. Well, I mean, I think I was thinking about this with the query group. I wonder what value there would be in bringing awareness, bringing people's awareness to how they're feeling around it, as opposed to, like, what is the value of that are people doing that anyway versus kind of knowing that this is expected? And so you're tuning in with yourself to like, how am I feeling right now? How am I feeling about this group? How am I feeling about the work? That's something that we've almost just go about without doing until it's really bad, kind of. I don't know that would be something to study, but I think there's value that could be added to that process. Who knows?
So many questions, so little time.
Yes, that brings us to the top of the hour. So I want to let people jump off if they need to, but thank you everyone for joining in and contributing. I appreciate it.
Thank you, Bridget, for doing it.
Yeah, absolutely. Yeah. Hope everyone has a great rest of their week. And reach out if you have any questions or need any of the articles, things like that. I can send it if it isn't on the website. All right. Bye, all.
Hey, thanks.